Good afternoon, and thank you very much for joining our webinar series. This is Module 3, which is brought to you in conjunction with EuroLUTS, the EAU, and the EAU Male LUTS Guideline Panel. My name is Christian Gratzke. I am a urologist from Freiburg in Germany, and I'm very happy to present this Module 3, which is about the impact of BPH on sexual function, together with Professor Andrea Salonia from San Raffaele in Milano, Italy. Professor Salonia is one of the most pronounced and profound experts on sexual function. The actual webinar will take place at June 1st at 6:30 and lasts 1 hour until 7:30. So please make sure you're available June 1st at 6:30 p.m. Central European Time.
So good morning, everyone. It is a real pleasure for me to be here with you today to try and very briefly introduce the content of the webinar which is going to come in roughly 1 week from now. The title is The Impact of BPH on Sexual Function. My name is Andrea Salonia. I'm a full professor of urology at University Vita Salute San Raffaele in Milan, Italy. I'm the current chairman of the EAU Guidelines Panel on Sexual and Reproductive Health. Why it is so important to deal with this specific issue? Since if you get a look to this paper, which has been published roughly 20 years ago, there was a huge impact of lower urinary tract symptoms on, I would say, against male sexual functioning. Indeed, at that time, Raymond Rosen and a group of friends published this very relevant paper, which was an epidemiological one, dealing with the concept that patients coming to the office because of LUTS and not because of sexual dysfunction, did also report a number of different sexual dysfunction, thus including erectile dysfunction, ejaculatory disorders, and low libido. What is relevant is that even at that time, coming to the real life setting, the higher the severity of LUTS, the greater the probability of suffering from ED, for instance. And the higher the severity of LUTS, the higher the severity of ED. It has been even the case for ejaculatory disorders. And what the authors did clearly report was that there was a huge connection with a different number of ejaculatory disorders, thus including premature ejaculation, painful ejaculation, anejaculation, or anorgasmia. Interestingly enough, it has been the case at that time. It is still the case even now, and data has been, increased over time. Just to say that both the EAU guidelines dealing with the non-neurologic or non-neurogenic male lower urinary tract symptoms and the sexual and reproductive health guidelines, they both deal with the connection between LUTS associated with BPH and sexual dysfunction itself. This is the case, for instance, for the latest version of the EAU guidelines on LUTS, and they were clearly telling us that it is compulsory to perform a comprehensive medical history in every patient coming to the office and seeking medical help for LUTS. If you get a look to the other guidelines, our guidelines, and I'm more than proud to have a number of colleagues coming from all over the world, I would say, since many of those are coming from Europe with different expertises, thus including urologists at most. Interestingly enough, we had outlined that there is a huge connection between LUTS BPH and erectile dysfunction and ejaculatory disorders, but certainly from the epidemiological standpoint, the most important connection is between LUTS and ED. And on the other side of the coin, even in men who have been treated because of BPH through endoscopic surgery, such as TURP, laser, open, or laparoscopic approaches, well, once again, it is so related with erectile dysfunction that a comprehensive medical history at the entrance, therefore, every single time a patient is coming to the office because of LUTS, should be performed. Interestingly, the diagnostic workup does include prostatic disease among those which have been considered relevant situations, even from the physical exam standpoint. And indeed, whenever a patient is coming to the office because of erectile dysfunction, vice versa, the patient himself, whenever he is older than a certain age, for instance, 50 years of age, they should be even considered for digital rectal examination. Therefore, there is a common ground fostering between erectile dysfunction, ejaculatory disorders as a whole, sexual dysfunction, and BPH. What is relevant from the very practical standpoint? Why should I ask for sexual dysfunction in a man coming to the office because of LUTS? This is a paper which has been recently published in one of our family journals, the European Urology Focus, by one of my group, Paolo Capogrosso. He was able to assess a number of patients who came in because of LUTS, not because of ED, but only because of LUTS, over a period of roughly 8 years. Interestingly enough, they came in, and they want to stress this point, because of LUTS. Interestingly, roughly 50% of those did also report ED according to the questionnaire, International Index of Erectile Function, which has been developed roughly 20 years ago by the very same authors of the first study I just presented, the one which was able to define that the higher the probability of having LUTS is associated with the higher severity of ED. And indeed, if you get a look to this paper and this cartoon, interestingly enough, there is a huge amount of patients who came in because of LUTS who did also report erectile dysfunction, which is a severe form of erectile dysfunction. Even more important, should I assess erectile dysfunction in every patient, or is there any rationale behind a different kind of choice? Well, interestingly enough, according to these models, which were able to assess from the multivariate standpoint whether non-assessing ED could be rational or not in the everyday clinical practice, if you got a look to the so-called risk factors, which have been considered as known risk factors for ED, age, IPSS score, diabetes mellitus, and whatsoever. Well, interestingly, IPSS was both considered as a key point associated with ED in both overall ED and severe forms of ED. And therefore, what we concluded was that there is no reason not to start considering that every patient coming to the office because of BPH LUTS should be also assessed for ED at the very same time. From the pathophysiological standpoint, after having telling you something concerning the so-called epidemiological aspect and clinical perception, it is important to say that there is a sort of continuum of relationships between conditions, which should be considered healthy or unhealthy condition. And this is the case even for LUTS toward ED. Interestingly enough, indeed, over the last 15 years, roughly, a great, I would say, an increase in discussion has been considered relating to the fact that a number of risk factors and comorbid conditions should be considered as potential risk factors for both LUTS associated with BPH and sexual dysfunction. This is the case, for instance, in this cartoon for smoking, obesity, hypertension, depression, diabetes, stress, anxiety, sleep disorders, and finally, metabolic syndrome. And I want to stress this final risk factor, which has been strongly associated with BPH as well. Therefore, not only from the clinical standpoint, but even from the pathophysiological standpoint. And indeed, over the last years, four theories have been developed concerning the potential association, which is a causal association between BPH and ED, starting from the autonomic overactivity and finally going to pelvic ischemia and passing through inflammation, androgen rho kinase activations, and so and so. One more issue, it is important now to understand that hormones may have a relevant responsibility. Those indicating testosterone, those indicating estradiol, and insulin resistance. And therefore, there is a huge connection, which is a common ground for not only from the clinical and the epidemiological standpoint, but even from the pathophysiological standpoint between the two conditions. Therefore, during our incoming webinar, we will discuss the issue that in men coming to the office because of BPH, we may have patients suffering from erectile dysfunction or impairment of erectile functioning, ejaculatory disorders, and low libido. I hope you will be many at our webinar, which has been planned next week. Thanks a lot for your attention.
So welcome to this presentation about novel technologies for the treatment of male lower urinary tract symptoms with a specific focus on sexual dysfunction. These are my disclosures, the companies that I've been working with over the past years. And you've heard Professor Salonia's talk on the impact of BPH in general on sexual function. Here, I would like to start off with a trial that was led by our colleagues from Weill Cornell in New York, Dr. Thomas, Dr. Chuck Tai. They did a very good search of clinicaltrials.gov, looking at specific keywords for BPH, such as benign prostatic hyperplasia, enlarged prostate, male LUTS, etc. And they looked for these keywords since the inception of clinicaltrials.gov and found more than 250 clinical trials in this analysis. What they found was that 70% of the trials were actually done on drugs, whereas only 26% roughly were done on devices and procedures, and only 3% were done on behavioral or dietary aspects. What's very interesting is the fact that there was a time especially at the 2000 until 2010 years, where there was a very high interest in BPH research, being it on procedures or drugs. And that interest has waned a little bit over the past 10 years. And I think we all realized that because there weren't any new drugs that were revolutionary coming on the market during the last 10 years. And we're hoping that this interest will come back again in the upcoming years. We found that only 30% of the trials use patient-reported outcomes, such as the IPSS, which is a bit disappointing, given the fact that PROs are of utmost importance. 79% of the trials were industry-sponsored. That's no surprise, given the high cost of a clinical trial. Only 42% had a 12 months follow-up, with the majority of having a follow-up of less than 3 months. Only 23% of the trials did report the results after all. So that study concluded that management options for male LUTS need unified benchmarks for success, adverse events, durability, and standard reporting for all clinical trials, regardless of the outcome. So what's the ideal technique? The ideal technique should be safe, reproducible, should lead to an optimal deobstruction, have minimal post-operative complications, have a short length of stay, a day case, surgery if possible, an ambulatory case. Should lead to a low retreatment rate, should meet patients' expectations and be cost effective. Now, of course, everybody agrees that there is no one-size-fits-all solution. We need a patient-directed, individualized approach here. So this classification has come up over the years as being a very sensible classification, stratifying into resection, vaporization, and enucleation techniques, and especially the enucleation techniques such as holmium or thulium enucleation have been on the rise over the past years. And that's shown here in this Korean study, and I think the very same data will be applicable to European data, where green light laser has gone down. You know, the green light laser came up in the early 2000s, also, you know, having the reputation of causing less sexual side effects. KTP is actually a bit of a false um, term for this because it was only considered a first generation of green light laser, KTP. But anyway, it went down over the years, as you can tell here, whereas TRP, what most people still consider gold standard, stayed about the same level. And then holmium laser enucleation of the prostate was on the rise. And it's still on the rise. And that's regardless of the age of the patients that's being treated. So again, what's the ideal technique? We have a problem here. We have a situation where in the field of male LUTs, we have a lot of RCTs, which is a very comfortable situation, but we are missing important parameters. So no systematic evaluation of prostate size has been done. Patients under anticoagulation are excluded, elderly frail patients are excluded, and sexual function remains badly evaluated. And that's exactly what we want to talk about in the upcoming webinar, June 1st at 6:30, because RCTs don't reflect our entire clinical practice. And regardless of how good we try to tailor our guidelines to our patients' needs, we need a patient-centered approach, and that's the topic for the upcoming webinar. So in specifically, I would like to talk about these emerging techniques such as Urolift, aquablation, Rezum, ITIN, embolization, and their impact on sexual function. Looking forward for you to join June 1st, our webinar, 6:30 p.m. Central European Time. Thank you very much.